So how was the exam? Did everybody live through it? In Rochester, you guys doing okay? Okay. So as soon as our wonderful flight attendants get done passing out refreshments, we will join in the Kahoot. So I'm going to go ahead and at least pull up that number. It's sitting on your table in front of you, folded up. There was one for every person. There should be a PDF for every student for the Kahoot questions. Here in the Twin Cities, I need to have your name tags up so I can see them. I haven't spent much time here in the cities, so nice, Allie. There's about 8 more players that need to get in. If you'll do that quickly so we can get started. Okay, anybody need another second? Raise your hand to get into the Kahoot, otherwise we're going to start. Okay, I'm waiting for you. All right, nice. Anybody else? All right, here we go. So, are you ready? All right. Patient says, nothing on the menu sounds good. What action will most likely improve their diet? Think about what the question's asking. So here we're looking at most likely improve the diet. So we need to get food in there that they will actually eat. So family members bring in favorite foods. We're looking for calories. We're looking for improving their diet. Ah, nice job, guys. Here we go. First thing to do when teaching an older man living in the community to improve nutrition. Older man living in the community. All right, determine who shops for groceries and prepares the meals. It isn't going to do you any good to do anything else until you find out who actually is preparing and buying the food, which will be the first action that you have to take, right? So first thing, think about when you look at your stems, first thing, okay? All right, Xavier, JW, Anna, Morgan, Pom Pom. Oh my, Pom Pom. Severely malnourished patient reports he's Jewish. What should be the initial nursing action? All right, ask the patient about food preferences. So here it's about 25-24. That would have been teach the patient about nutritious kosher foods. So teaching would definitely not be a first action, because you can teach him all you want, but until you really know what he wants, remember we have to get patient-centered and find out what kind of foods he can even eat. He probably knows more about kosher foods than you do, so teaching him about kosher foods, maybe not first thing you should do. All right. Oh, Pom Pom, look at there. You moved right up. All right. The patient needs to be in what for optimal healing to occur? Nice. Okay, it's positive nitrogen balance, and that's just something that you need to know. That would mean that proteins are around and available for actually healing to make to happen, for tissues to renew. Oh, Emma, look at you just bumping people down. Good job. The nurse is assessing a patient for nutritional status. In doing so, the nurse has to what? All right, nice job. Good job. So you never want to take one piece of information, subjective or objective, and make a determination on it. And that would not only go for nutritional status, but it would go for lots of other things too, okay? You need lots of information in order to make some decisions. Good job. All right. Oh, Emma's coming up here. This section of the intestines is where most nutrients are absorbed. Yay! Most of you understand that the small intestine is where most of the nutrients are absorbed. So if perhaps a patient, when we talk about patients with elimination issues, when we talk about different parts of the colon that are missing, then you know that they can be malnourished or have some problems with nutrition. All right. Oh, Pom Pom's all the way at the bottom. Come on, Pom Pom, you could do it. Okay. Medical nutrition is used to treat what? What are we going to treat with medical nutrition? Oh, you're all right. So, what would be a diabetic diet? Anybody? What kind of diet would a diabetic have? Low sugar, low carbohydrate, right? If we think about hypertension, can you guess what kind that would be? Anybody in Rochester? Want to take a stab? What?
Low sodium.
Low sodium, perfect. And there are some other nutritional things that we can do to treat bowel diseases and cancer. Nice job. Oh, Pom Pom, you disappeared. Come on. Name of the primary protein in the human body. This is very important. And that's a picture of it, by the way, if you can recognize it. All right. It is albumin. Albumin is very important in the human body. It is the primary protein that transports both hormones and different kinds of nutrients throughout the body. Okay, so it's the protein that gets on the highway, that delivers everything all over the body. It also binds to drugs. So if there isn't enough albumin available, sometimes patients can get toxic much quicker. So we need to keep an eye on albumin, okay? All right. Which one of these diets is used to prevent aspiration pneumonia? Perfect. Good job. Today you're going to get an opportunity in case you haven't already noticed. All right, Anna R. coming up the leaderboard. Okay, which one of these problems is not associated with metabolic syndrome? Okay, and that is something that you'll need to know. I would maybe star that for the exam. All right, here we go. Someone could be under or overweight and be malnourished. What do you think? It's very true, okay? So malnourished is simply that they don't that they don't have enough nourishment. So it doesn't really matter. Overweight people sometimes are overweight, but they're not getting the right nutrition, okay? So they can be malnourished as well. All right, nice job. Here we go. Enteral feedings are for patients who cannot ingest food but can digest it. Ingest, digest. That is true. The enteral feeding must be able to go in and it must be able to get out. Okay? You can't keep pumping something into the body that you can't get out. Okay? So you have to have an intact GI system. Nice job, Anna. All right, nurses do not need to be concerned about aspiration in patients with enteral feeding. Good. That is false. In fact, that's one of the primary ways patients can get aspiration pneumonia is people not maintaining the head of the bed at the appropriate angle and having them sit up for the length of time that they need to. All right, here we go. NAR, good job. Okay, this little mouse is crazy here today. Patients can receive enteral feedings in the hospital or nursing home only. That is not true. So patients are many times getting enteral nutrition at home. Family takes care of it or the patient takes care of it. And when they come into the hospital, it's interesting because if it's that kind of patient, they do their own feedings even in the hospital, and a lot of times they will teach the students about how to manage tube feedings. So it's really an interesting deal. All right, so Xavier, you're hanging in there. JW, good job, Maddie. Anna R, you guys are going to have to try hard to kick her off. All the following except blank are reasons for the older adult to be at risk for malnutrition. All except. Okay. So there we're talking about thirst sensation. Okay. So malnourishment deals more, remember, thirst sensation deals more with like fluids, so it can even be water. There's not a lot of nutrients in water, although it does play a part in there. This would be the one that would be most applicable here. And that's it. Anna R. Pom-Pom, look at you sneak in there. JW, good job. All right. We're going to leave that little site now just for fun. Okay. And then let's go to the PowerPoint. All right. So we're going to talk a little bit about aspiration prevention, because it is really, really important. You're going to be dealing with patients in the hospital who have many difficulties. Sometimes it's like a stroke, and so they'll have some type of dysphagia or an inability to swallow correctly. Sometimes they will be also on enteral feedings or other kinds of diets. So we have to think about what do we need to do to prevent aspiration. So modification of foods and liquids, okay? Thickened liquids are easier for patients to control in their mouth. Does that make sense to you? So we know that when we eat, right, we get that bolus in our mouth, we chew it, we kind of work it with our tongue, and then that bolus goes down our throat, right? When we put really thin liquids in there, what happens? It kind of starts to go without that bolus, right? And so you don't really have to make that swallowing action. It can actually get down the esophagus without swallowing. So patients are more at risk when they are thinner liquids. So thickened liquids you'll find are used in the hospital and at home, in nursing homes and different things to help prevent aspiration. It also prevents premature entry of liquids into the pharynx, which was what I was talking. So the thin liquids enter that prematurely. Positional swallowing maneuvers, you can also ask people to kind of tuck their chin, okay? So this is not a good position, right? Because things can get in there that you don't want to. If you are like this, you have to actually think about that motion and make that swallowing motion for things to enter. Provide rest periods. So this is particularly important when you're dealing with really sick patients or older patients, okay? Sit the person upright at 90 degrees or as close to 90 degrees as possible. Never, ever, ever, ever give anybody anything to drink while they're laying down or less than 30 degrees, okay? You're kind of asking for it. So when you come in a room in the morning next year and you're going to give a patient their medications and you put the head of the bed up just a little, that's dangerous, okay? I know they're tired, they just woke up, all that, but get them up at least 30, 45, and even higher is better. So do an assessment of your patient, okay? Think about if this is an older adult or someone who's having trouble swallowing, you want them as high as they possibly can be. Get them to take their pill, tuck their chin, okay? Those kinds of things, all right? And avoid rushing, okay? So you may have to sit with somebody for 10 minutes, 15 minutes while they take their pills or get some hydration or some food, okay? I know that it's very tempting and you feel like you need to rush. There's other things for you to be doing. Perhaps all the aides called in sick, and so you're going to have to be doing aide work, nurse work, everybody work. Do not rush your patients, because what it means for them, if they get aspiration pneumonia, is they get pneumonia, they get sick, and they die, okay? So it's really not worth it, okay? Each patient you have to care for in a safe manner, okay? And then alternate between solids and liquids just like you do at dinner, okay, or breakfast or whatever. You have a little coffee, you have a little cereal, okay? Some of the most common side effects of thickened liquids, yes, there are side effects. It is a therapeutic diet, okay? Some of them are the taste and the texture, as you will find out soon, are kind of unpleasant, okay? So they can cause a decrease in fluid consumption. Also, if you think about the amount of time that it takes to get enough hydration for, let's say, 2,000 milliliters is the average for the adult, right? How long does it take to spoon honey thickened liquids, okay? So you're not going to be able to drink that like you do your 2-liter bottles of pop and things like that. It takes a long time to get the appropriate amount of liquids, okay? They actually are less hydrating than regular liquids because of the thickener in it. They also make you feel more full, okay? And so you don't really want, and remember with our older adults, they already have a decreased sensation of thirst, right? So they might feel full and they may not want to drink as much as they should. So remember, one of the top 5 diagnoses responsible for hospital readmissions is dehydration, okay? And it's also one of the top 5 that happen while they're in the hospital, okay? So dehydration can cause confusion, urinary tract infections, falls, weakness, and a decline in function, which just means more reasons to go to the hospital. So it is a pretty big deal, all right? So with that, we have some wonderful things that you can partake of. So we have a small cup of, it's a little bit different in Rochester. It's going to be exactly backwards than it is here. So our water is, which one, Rainey, here in the cities?
They're both thickened. One's thicker than the other.
There you go.
You guys figure it out.
There you go. So
you figure it out.
each one take a little sip of each. You should never ever ask someone to do something that you don't know what it's like. So when you take that little sip of water that is thickened, I want you to understand what you're asking people to do. Okay?
Did it hold one out? It's a little funny, but kind of gives you a better taste of how.
Isn't that wonderful, Hannah? Yeah, it smells good
It's not. I'd rather this than powerful.
Oh.
It's just the texture. It's just naturally.
Okay, so I want to give you guys a little bit of direction. I see most of you are done tasting. So what I want you to do is engage in a conversation at your table. Things I want you to think about is, which one would you rather drink if it was the right? I mean, don't think about the texture, even though you can say one is harder to drink than the other. But what kind of strategies can you think would be useful to help people get the amount of hydration that they need while they're on thickened liquids in the hospital? So why don't you talk about that at your groups for just a minute, and then we'll get back together and talk about that.
Did somebody turn it on? I don't know how many.
Okay, in Rochester, let's see, let me look at my little groups here. How about Kate, your table? What do you think? What kind of strategies would you use to help people get enough hydration if they were on thickened liquids?
We would say to encourage like whatever they like. They like orange juice more, give them water, make them drink more, whatever they like more.
Absolutely. So asking them what they like to drink is going to be an important thing. I've had a lot of hospital patients and nursing home residents who just love it in their coffee. They love coffee. They don't want to give up coffee. So it can be warm, it can be cold, and you can thicken really any flavor that they like. So that's one good strategy is flavor. What else? Yeah.
And what temperature they like their drinks at, whether if they like it cold or like room temperature.
Perfect. So Jasmine here says temperature. Temperature is a huge issue. I am like a freezing cold person. If that was like at room temperature, I don't drink water at room temperature. And so what you'll see is a lot of times people who are working on the floor just simply drop something off. Like they're not trying to make sure that it's going to be a pleasant experience or that someone might want to repeat it over and over so that they would get the right amount of hydration. Brandy.
So, can the patient deny thickening their liquid if they absolutely hate it?
Well, remember, what would you do if they wanted to deny it? Why are they getting thickened liquids? Because we're mean?
No.
Okay, why? Jasmine?
You could educate them on like the risk of aspiration.
And death that comes with aspiration, yeah. So they can deny drinking. I mean, I think it's a good question. They can deny drinking it, and many people don't like it. So you want to find any way, if it's temperature, if it's flavor, if it's having a family member there, if it's sucking it through a straw, if it's using a spoon, you want to do whatever you possibly can. The problem is if they drink liquids without the thickener in it, they are more likely to get aspiration pneumonia and actually die. So it's very bad, okay? On the other hand, they need to be getting hydration. Sometimes folks don't get enough stuff because they don't like the texture. Even if it's a pureed meal with thickener in the fluids, yeah, that's super yummy and it looks excellent too, right? So we do have people who don't eat enough and people who don't drink enough, okay? And we're going to talk about what happens maybe to some of those folks. So good question. Anybody in Rochester have anything they want to add?
You ready?
Okay, I'm moving here into the Twin Cities. Yeah, over here, Shannon.
That's Ashley.
Ashley. But
Oh,
sorry.
so I see. Tricky. Okay.
So would the risk of aspiration apply to things like Jello or applesauce that are a lot softer? Because could you say well, you can have a spoonful of Jello if you drink so much of this
Super.
liquid.
Super.
Because it's an incentive because it
You
tastes
bet.
so much better.
Absolutely. Isn't that like if you eat 3 peas, I'll give you 1 French fry, right?
Yeah.
That kind of deal? Sure, Shannon.
If patients were in more of an acute care setting, is IV rehydration still an option, or is this
Parenteral fluids, so they can get fluids from an IV, okay, only for a certain amount of time. Okay, so it's going to keep them from getting dehydrated to a certain point, but the problem is we need to get them actually getting better, getting out, getting home, those kinds of things. So yeah, IVs can definitely be used to help. Yep. Yeah.
I may have missed this, but so thickened liquid diet is generally just for the older adult population, correct?
No, in fact, on Tuesday I had students at the West Bank on a med-surg floor, and we had a patient who was an Asperger's patient, fully functioning, very high functioning. He had a job, he was able to speak, he was doing everything, and all of a sudden he became fairly catatonic, was unable to really communicate his needs. He had micro seizures, so they were wondering whether he had malignant neuroleptic syndrome or if he had a malignant catatonia. So he could kind of talk to you. It wasn't really noticeable, but he had to be on thickened liquids. So we would just raise the head of his bed. And he was so thirsty, we kept running out of thicket, like literally. So we kept calling down to dietary. We're like, no, like bring a lot. And so, they bring 5 or 6 packets, and it's like, no, like a lot more, because he kept running out every 10 minutes. So, yeah.
So, but he wasn't able to drink.
He wasn't able to swallow correctly.
Okay.
Okay? So remember, anybody who's not able to swallow correctly, and so younger people have strokes as well. They also can have other neurological kinds of things going on, other neurological diseases. Yeah.
How do you test proper swallowing in the first place?
So that's a good question. There is in your Potter and Perry book, there is a wonderful aspiration assessment, okay, where you have, it's a swallow technique where you put your hand and you see if they can swallow. You give them a very small amount of thin liquids and see if they cough, see if they're swallowing. Generally, they will have speech therapy or sometimes occupational therapy come and do it in the hospital, and they do a full kind of assessment and even decide if they do need thickened liquids at which level. So honey thickened, if they need nectar, which level of thickening they need to be safe. Good question. Okay. So one thing I want to talk about now, did any more questions in Rochester before we move on? Okay, I want to refer to one of the documents. Well, let's see here. Did that document not download? I guess not. Okay, so on your Canvas site you have types of therapeutic diets. So it should look like this, okay? I'm not going to read this all to you. We're not going to go through all this, but I would know this for the next exam, okay? So common reasons for therapeutic diets. So we want to think about nutritional status to either maintain, restore, okay? Sometimes we want to increase more protein so that we stay in positive nitrogen balance in case we have tissue healing that needs to occur, okay? Common therapeutic diets would be like diabetic diets, low sodium, things like that. Texture modification, that's for dysphagia and swallowing issues. So you can have a mechanical soft diet, a pureed diet. Oh, poor those people that have pureed diets. That's another thing. Do everything you can to try to flavor those things because they just look terrible. Food allergies, that would make sense. Tube feedings. So here I want to talk to you about common therapeutic diets that we see on med-surg floors, like a clear liquid diet. So after a person comes out of a surgical procedure, a lot of times before, so they've been on an IV, they were NPO before the surgery, right? They've been on an IV. And so now they're starting to feel a little bit hungry. We've assessed for bowel sounds. We know that their bowels are working. You never give anybody anything to eat or drink until we know that it's going to actually move on through, okay? But the very first thing we want to do is give them clear liquids, okay? Because it's the easiest thing to digest. Clear liquids simply means clear liquids. You can actually see through it. So Jell-O, okay? That would be a clear liquid. Another thing that would be clear liquid would be like a Sprite, okay? Juice. Now, it can't have pulp, but if it's like a apple juice that you can see through, broth you can see through. Now, when we think of full liquid diet, it gets more creamy, okay? Here we're talking about things that are custardy, cream soups, ice cream, pudding. I would know those for the next exam because you might be given an example of someone with a certain problem and you're going to have to find the best kind of diet, okay? We're also going to be talking about diabetic diets when we go through glucose management. So just take a peek at the types of diets. That's all I'm going to present on that. Any questions on that before we move on? All right, here we go.
Any questions?
Okay, so mostly today, what your PowerPoints were and your study guide was kind of basic nutrition, okay? You had a nutrition class. I'm not going to spend my time going back over, myplate.gov and all that kind of stuff. I think you guys are super fine without that, okay? So we're going to really talk about nutrition in terms of tube feeding. So enteral nutrition, also known as tube feeding. Now, they're the administration of liquefied food or formula, and it goes through a tube that's inserted into the stomach or the duodenum or the jejunum. I'm going to go back to this picture right here. So you can have NG, which means nasogastric, starts in the nasal cavity, ends up in the gastric or the stomach, okay? You can have ND, nasoduodenal. In other words, it starts in the nose and will go down into the duodenum or the jejunum, okay? And we'll talk about why we would put them in different places. We also have a gastrostomy, which simply goes from the outside of the stomach to the inside of the stomach, all right? And we can have a GJ tube, which goes through the stomach and goes down into the jejunum, okay? So we'll talk about why we would do that or not. So it provides nutrients alone or supplemental to oral or parental nutrition, okay? So patients do not need to not be able to eat at all, okay? Sometimes we give them extra because they either are becoming now malnourished or are at risk for malnourishment. So sometimes it's alone, that's all they're getting because for whatever reason they can't swallow. So we have a lot of patients on our oncology floors who've had throat cancer or cancer of the mouth, okay? And so basically they don't have a tongue or they don't have some of the pieces or parts up here that they would need, okay? That would be a patient who has enteral feedings alone. That's all that they have, right? But we might have an elderly patient who has been losing weight. They eat a little, very little. Maybe it's a pureed diet, maybe not. Maybe they can eat whatever kind of diet they want. They just are losing, okay? And so we might insert a feeding tube and help them be able to get more nutrition, okay? It's very easily administered. In your lab sessions in the spring, you guys actually will get to be doing that with the mannequins. So what the difference is between enteral and parenteral is the enteral goes into the stomach. Parenteral goes into into your veins, okay? So parental is much more dangerous, okay? It's also much more expensive, all right? Has to be monitored much more closely. And I know you guys have some blanks here and there, so let me know if I'm going too fast, okay? It's more physiologically efficient than parental. Parental is nothing but it's just liquid that's going into those veins, so it's doesn't resemble food at all, okay? So indications or people who often have feeding tubes are sometimes patients with anorexia, if it's appropriate. Okay, orofacial fractures, so maybe they only need it for a short period while that heals, okay. Head and neck cancer. Patients with burns. Patients with burns are using calories probably 5 times more than your average person because they're healing, maybe even more than that, okay. So they need as many calories as they can possibly get. and they need to remain in that positive nitrogen balance for sure. Nutritional deficiencies, so if for some reason there's a deficiency of something, we might be, maybe it's protein, again, maybe it's we want to buff that up for protein, maybe it's high fiber, psychiatric conditions, chemotherapy, and radiation therapy. So we already talked about these common locations. So gastrostomy and jejunostomy tubes may be used in those needing feeding tubes for an extended period of time, okay? NG tubes, ones that go through the nose and into the stomach, okay? We don't want to use them for a long period of time. Anybody tell me why they think, and you can just take a guess. Anybody in Rochester? Anybody here in the cities?
Uncomfortable.
Uncomfortable. Very uncomfortable. Absolutely. And what? Go ahead.
I have a comment, Rochester.
Break down the mucosa of the Nurs.
Perfect. Yep. So we have tissue breakdown in the Nurs. It's very uncomfortable. Patients don't like it. And so really we don't do it. If we think about, I've heard different docs say different things, but I would really say 5 days would probably be the max. Really, it's very easy to pop in a PEG tube, and we'll talk about that. It's a gastrostomy tube, a particular kind of one. To pop it in for even if we only thought we needed it for 5 days and take it back out. It's very easy, heals very easy, it's not expensive to do. There's less chance of aspiration. It doesn't mean that it totally is aspiration free. The patient must have an intact, unobstructed GI tract, and that's for any patient who's getting an enteral feeding. Remember I said what goes in's got to come out. Okay, we got to go in and we got to come out. All right? So assessing bowel sounds is very, very, very important. Okay? It can be placed surgically, radiologically, or endoscopically. Today we're going to talk about endoscopically placed. So that's our PEG tube. Okay? So here again is just another picture of where they are and how far they go. You're kind of a picture person. So percutaneous endoscopic gastrostomy is a PEG tube. Okay? It's a particular kind of feeding tube. Percutaneous means it goes through the skin. Endoscopic means that it's placed by endoscopic procedure. And gastrostomy means that it's generally in the stomach. However, we can also have these PEG tubes with a piece that goes down into the jejunostomy, or jejunum, excuse me, or the duodenum. Okay? There are fewer risks than a total surgical placement. A lower cost, minimal sedation, so it's a conscious sedation, kind of a twilight sedation. So we don't need to put them on a breathing machine, all of those kinds of things. Okay, I have a video here. We're not going to watch all of it, but I do want to show a few pieces of this. I need for you guys to take good notes, okay? You're going to be doing a case study in a little bit, and it's going to ask you some questions that come from the video. I also want for you to pay particular attention to what the nurse is doing. What is the nurse doing this procedure? Okay, she's a very important part of it. And I'll tell you, it's a little bit old, and I'll tell you when the doctors are really doing things that nurses do. Kind of like on Grey's Anatomy.
This program will provide an in-depth look at percutaneous endoscopic gastrostomy, PEG. This technique represents a critical component in the care of patients requiring enteral feedings. The program is divided into sections.
Because it's a little long, I'm going to buzz us through this first part.
PAC. Patients with a wide variety of conditions may be candidates for PEG tube placement. In general, this intervention may be considered for an adult, a child, or an infant who is unable to eat.
A patient who should receive a PEG tube is someone who's going to need some enteral feeding, meaning feeding through the digestive system, for at least 2 weeks. And these are patients who either cannot or will not swallow.
In adults, probably the primary patients you see with difficulty swallowing are patients who have undergone a neurological problem, such as a cerebrovascular accident, a CVA, and also you'll see it in patients who have dementia, and it could be Alzheimer's or non-Alzheimer's dementia. Many times in younger patients, you might see patients who have had esophageal tumors and are maybe preparing to have radiation therapy and are currently unable to swallow. You can also see it in patients who have other neurological impairments like multiple sclerosis that actually affects the ability of the esophagus to pass food from the mouth to the stomach. In children, it's different scenarios. Sometimes it's a case of some type of genetic impairment. It could be an oral problem like cleft palate, cleft lip. Sometimes it's just early neonates and children who have failure to thrive.
PEG tube placement is contraindicated in patients who are receiving anticoagulants or have an obstruction of the esophagus, which may prevent the introduction or removal of the tube. The inability to clearly identify a safe percutaneous entry site also precludes PEG tube placement. Finally, a PEG procedure is contraindicated in patients who have had multiple surgical procedures near the gastrostomy site, or those who have medical conditions that would put them at high risk during the procedure.
Consent is very important. Also walking them through the issues about the possible complications from PEG tube placement, whether it's bleeding or causing infection in the gastric wall or perhaps in the peritoneal cavity, or even having some respiratory problems with the procedure from the anesthesia, and walking them through those to let them know that there are some complications, although they're relatively rare. On the day of their PEG tube procedure, the patients maintain NPO. And I do use pre-procedural antibiotics. I think there's some controversy regarding this, whether you need to use pre-procedural antibiotics, but when you look at the preponderance of evidence regarding this.
I'm going to move through that yakety-yak.
Tube. PEG tubes are inserted using a method that utilizes the visualization capabilities of endoscopy to provide the patient with the advantages of less invasive percutaneous access. PEG tubes are placed into the stomach. A J tube can also be placed through the PEG tube to deliver nutrients directly into the jejunum. PEG tubes are available in a variety of designs. Some are used to...
These are all just different kinds of PEG tubes, some for children, some for adults.
Very secure, requiring vigorous pulling for removal. This allows for formation of a well-healed stoma. This type of bolster also provides an advantage with combative or demented patients who may become confused and attempt to pull the PEG out. The balloon-type internal bolster is the option most often seen with replacement PEGs. The balloon-type bolster is generally less durable than the solid bolster. However, due to its inflatable-deflatable design, it is intended to be more easily removed when necessary. The external section of PEG tubes also comes in two options. With the first option, the tube extends out from the patient. The second design is referred to as low profile because the entry port for the PEG is integral to the external bolster and is therefore very near skin level. The low profile device chosen must be long enough to allow positioning of the internal and external bolster without creating tension on the tract.
And children.
The original PEG tube design makes the feeding process easier for nurses and caregivers as it allows more of the tube to be grasped, making syringe or feeding tube attachment easier. The low profile design is much less.
All right, we're just about getting ready
for
to
placement.
do it. So pay
These
attention
kits
to how
may be
this is
supplied as a
actually
single
put
bag,
in.
single tray, or two-tier tray system. Two-tier tray systems are preferred since they organize the equipment in a way that increases the efficiency of the procedure. The top tier contains items required to prepare for PEG tube placement.
We don't care about their top tiers. But we are going to care here in a
Procedure,
second.
the patient is positioned supine with the head elevated and appropriate conscious sedation is established. Oxygen may be provided via nasal cannula and the oxygen saturation levels are monitored by pulse oximetry. The posterior pharynx is anesthetized and a bite block is positioned in the mouth. Particular attention is paid to posterior pharyngeal suctioning. These preliminary aspects of the PEG.
So this is the nurse, the guy with the black hair on the other side. So he'll be suctioning this patient because she's not really managing her secretions, but she can breathe on her own, okay? So she doesn't have to have a tube down there. When they say conscious sedation, she has like fentanyl, Versed, those kinds of medications on board. So she doesn't feel anything. Basically, she's asleep, but he will have to suction her mouth to keep those liquids from going down in the back. So basically, he's kind of managing what's going on there, and he'll be doing some other things.
Procedure relating to patient positioning, oxygenation, and suctioning are
all
critical.
of those things.
The endoscope is advanced, and the esophagus, stomach, and proximal small intestine are examined. The endoscope is then pulled back into the stomach, and the stomach is insufflated.
This is just a tube with a light
Insufflation
on
during PEG
it?
tube placement is critical, and this is done by air passed through the endoscope. Without insufflation, you can't see anything.
Insufflation
By
is just putting
insufflating the
air
stomach,
in there.
you actually move the stomach up towards the abdominal wall, so that the distance that you actually have to penetrate the needle through the abdominal wall into the stomach is shorter. So good
he's in the
insufflation
stomach.
is critical to an adequate PEG tube procedure.
The light from the endoscope is directed at the abdominal wall. With the lights in the room dimmed, a translumination effect is seen, generally in the left upper quadrant of the patient's abdomen. At the point where the translumination is most clear, finger pressure is applied.
There you go.
The indentation of the gastric wall produced by palpation is noted endoscopically, and the site is marked. The site is then prepped using standard technique.
All nursing.
A snare is advanced through the biopsy channel of the endoscope and positioned at the proposed entry site. After a sterile prep of the site is completed.
Okay, so he's using that same endoscope that has the light on it, and he's putting down in it kind of a wire that's going to kind of go down in there, and it's got a little loop on the end of it. So this thing with the light also can take like a cannula. It's going to go down in there, and you'll see he's going to poke a needle through the top, and he's going to grab it with that loop, okay? So that's kind of what's going to be going on there.
Local anesthesia is administered. The needle is then advanced through the gastric wall while pulling back slightly on the syringe plunger. Safe site selection is confirmed when endoscopic visualization of needle tip entry into the stomach corresponds with air entry into the syringe. A 1 to 1.5 centimeter incision is made at the entry site. This incision must be sized to accommodate the diameter of the PEG tube that is to be inserted.
From my perspective, it is better to have too large a wound than too small a wound. If you make too small a PEG tube cut, then as you pull the dilator in the PEG tube through the abdominal wall, the tissue around the PEG is compromised. It's tight. There's lack of blood flow, and I think that leads to PEG tube leakage and wound infections. So I generally like to see my incisions be somewhere around 1 to 1.5 centimeters.
The needle cannula assembly is inserted through the incision into the stomach under direct endoscopic visualization. The snare is closed around the cannula and the needle is removed. The looped insertion wire is passed through the cannula into the stomach. The snare is loosened from the cannula and tightened around the wire. The wire, snare, and endoscope are removed together from the patient, and the wire is removed from the snare and scope. The insertion wire exiting the patient's mouth is attached to the tapered dilating segment of the PEG tube. This is accomplished by inserting the big loop of the insertion wire through the little loop on the PEG tube. The PEG tube is then threaded through the big loop, internal bolster end first, and pulled to tighten in place.
So now what's going to
The
happen
tube
is
is
when they
lubricated,
pull that whole thing
and the insertion wire
down,
segment at the abdominal
then the
wall is
bolster will be
continuously
at the
pulled
stomach,
until
and the
first
tube
the
will-
dilating segment and then the
will
PEG
come
tube
out.
itself exits the incision.
So here comes all the
The
tubing.
tube is pulled until the internal bolster
And that
seats
bolster is
snugly
gonna be
against
what
the
sits in
gastric
the tummy.
mucosa. The insertion wire is cut, and the external bolster is advanced over the PEG tube to a point approximately 1 to 2 centimeters from the abdominal wall. The PEG tube is cut to a comfortable length for the patient. The external Y adapter for feeding is plugged into the open end of the tube. The larger arm is the port for the formula, and the smaller arm is the port for administration of medications. The caps on both ports should remain closed, except while in use.
So that smaller port for medications would be only liquid medications, okay? It's very important when you're dealing with giving medications by gastrostomy, is that you make sure that, because you'll have to be crushing medications. Some of them you can't get in a liquid form, okay? And you don't want to have all those little tiny particles getting stuck and clogging up those holes, okay? So just a FYI.
The endoscope is reinserted to confirm proper positioning of the internal bolster against the gastric wall.
There you go.
The external bolster is adjusted as necessary so that proper tension is achieved. A sterile dressing is applied to the abdominal entry site. 24 hours after the PEG procedure is complete, the tube can be utilized for feeding. The push technique for PEG utilizes a guide wire rather than a loop be confirmed. To do this, 5 to 10 milliliters of water should be drawn into a syringe.
Feeding. Doesn't happen
if the patient is a child, 3 to 5 milliliters of water should be used. The cap on the larger port of the PEG tube is opened, and the syringe is attached to the port. A stethoscope is positioned on the left side of the abdomen just above the waist, and the water is injected while auscultating for a bubbling or gushing sound.
So, verification of placement is absolutely X-ray now. Verification of placement is X-ray, okay? Although you might see, if you can hear bubbles or whatever like that afterwards, the reality is the very first time this person, once she got out, they probably brought in a portable X-ray and just made sure that it was in the right place, okay?
Hearing that sound during the assessment process is an important indicator that the tube is in proper position. If no sound is heard, injection is repeated. If no bubbling is heard after this repeated attempt, the feeding should be withheld and the physician notified. After the bubbling sound is heard, stomach contents should be gently aspirated into the syringe to check the amount of residual.
So that's what's left in the stomach, okay? We do that every single time we put food in, is after we're done, before we put something else in, we check and see how much residual is left, okay? And the residual is kind of an indication of how the rest of the bowels are working, okay? And so if the bowels are not working and the formula is not moving, okay, we need to do some assessments. We need to find out why. Are we putting it in too fast? Is the patient not tolerating that particular kind of formula? What's going on? We're never going to just keep putting it in, okay, until that residual gets back down. And a doctor will leave an order how much residual you can keep giving them feedings with. And it's kind of different. Sometimes it's 100, sometimes it's 200. I've seen it both ways. Just kind of going to depend. So that's what residual is. You're checking to see how much is left in the stomach before
the amount of residual is compared to the guidelines set by the physician. If the amount conforms to the guidelines, it is re-injected and the tubing flushed with water. The feeding can then be administered.
Throw it away.
If the residual amount is too high, it should be re-injected and rechecked 30 to 60 minutes later. If it remains too high, it is again re-injected and the physician notified. However, if it is within guidelines, the patient can receive their feeding. The flow of formula during a PEG tube feeding is regulated according to physician guidelines. It can be delivered via a bolus method using a syringe, or by a continuous method which utilizes a pump. Bolus feeding allows for delivery of formula over a short period of time. The technique will vary depending upon the PEG device that the patient has in place. If the patient has a standard PEG tube, A gravity feeding method may be used. The syringe is connected to the end of the tube and formula allowed to flow in by gravity. Adjusting the height of the syringe alters the rate of flow. After the feeding is complete, the tube is flushed with water to maintain patency. If the patient has a low profile,
So patency means that the tube remains clear and fluid will go through it. So that's what they're doing, is making sure that it doesn't get clogged up with food particles. Okay? And I think this is another
button
part
peg,
we're going to
the
skip.
anti-reflux valve.
Dun, 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 dun. Not to go too far past. He's still doing some. We're not going to go over care of the equipment.
And if they need to, they can wash it with warm soapy water, but be sure that they rinse it thoroughly and dry it and keep it in a safe, dry place.
This is important.
Mouth care is very important for the PEG patients. I think sometimes we forget that because we're feeding them through an alternate source, that Mother Nature's natural route is neglected. Mouth care is very important, and that usually consists of if a patient is able to brush their teeth, good oral care, and lip balms to moisten the lips to keep them from cracking.
The stoma, or skin entry site for the PEG tube, should be cleaned daily. Initially, hydrogen peroxide on a cotton swab or small piece of gauze may be used to clean around the site. During the cleaning process, the tube should also be rotated to ensure that it moves easily in a full circle. If it does not, the physician should be notified. As part of stoma care, the site should be assessed for redness, pain, or soreness, swelling, or...
After those first couple of days, the hydrogen peroxide just helps get rid of the blood that's kind of on there from the actual procedure. So, I mean, we're talking like 1 time, 2 times max. Hydrogen peroxide's super hard on patient skin. Just some mild soap and water, or even just water on a gauze generally will clean it just fine. So don't use a bunch of harsh agents on the skin.
or drainage. If any of these are noted, the physician should be notified. A dressing is then reapplied with the drain sponges positioned over the external bolster.
Under.
After a few days of healing, the site can be cleaned with mild soap and water and left open to air. There are various methods of securing the PEG tube.
Only thing I'm going to say about that is don't put a bunch of skin all over somebody's belly and wreck their skin.
When stoma care is...
Yeah, what did I say?
You said skin.
Okay. Yeah, I'm trying to do 2 things at once, like my brain is getting too old to do that. I should know that. Okay, here's some troubleshooting.
allowed to drain as prescribed.
All right,
While caring
important.
for a patient with a PEG, there are some problems that may be encountered. This section will discuss management of nausea and vomiting and the potential complication of aspiration, constipation and diarrhea, leakage around the tube, and backup of gastric contents into the tube.
If the patient has a tendency to develop nausea and vomiting, that would be one of the scenarios where you would ask the patient to potentially move maybe from a bolus feeding to move to a continuous feeding over several hours. Sometimes it's the quantity of the feeding that may be causing them to be nauseated. They might try different types of feeding products. They might try something that's diluted with water, a little more water, and kind of troubleshoot what could be causing the nausea. You may want to make sure that the feeding substance is at room temperature and is comfortable for it to be placed into the stomach. You'd be very careful to check your residuals because it could be that the patient's unable to process the food from the stomach into the duodenum. If the patient does develop nausea and vomiting and has a risk for aspiration, you would definitely want to keep the patient upright and get them into a physician or to an emergency room very quickly because you are at risk of aspirating if the patient can't swallow and is still bringing up some type of feeding. And you would also, of course, want to stop the feeding at that time and determine what the cause of the vomiting is.
Constipation and diarrhea can indicate a need to change the formula, the feeding schedule, or both. It could also be related to another problem, so a complete assessment should be done.
Constipation, or the opposite, diarrhea, can be a complication of tube feedings. It's very important for the patient in the home setting to contact their physician and let them know right away. Of course, we don't want these patients to become dehydrated through chronic diarrhea, nor do we want them to be obstructed from chronic constipation. So again, it's very important for them to immediately inform their physician of their particular situation.
Leakage around the tube or button can occur. This may be due to improper patient positioning during feeding. Keeping the patient upright during and after the feeding may resolve this problem. Leakage around the tube may also result if the tract enlarges. This may be prevented by proper stabilization of the tube without tension. If the patient gains weight, the external bolster may need to be repositioned. If the tube has a balloon, increasing the amount of water in the balloon may also help stop leakage. A decrease in gastrointestinal tract function or a feeding rate that is too rapid can cause leakage around the tube. An assessment of residuals will reveal if that may be the cause of the leakage. If residuals are high, decompression, a change from bolus to continuous feeding, or a decrease in feeding rate may prevent further leakage. The cause of leakage around the tube must be determined and corrected to avoid skin irritation. To maintain a healthy stoma site, the skin must be kept clean, dry, and free of drainage. To protect the skin from drainage, a waterproof barrier around the site may be used. High residuals may cause a backup of gastric contents through the tube. This may also be caused by a failure to properly close the ports on the tubing. Again, residuals should be monitored and all connections within the system checked for security.
As a gastroenterologist or as an endoscopist, many of us feel that once you put your PEG tube in place, that your job's done. And in fact, your job's just beginning. As I explained to my colleagues, the PEG tube placement is the longest implant that an endoscopist puts in a patient. So the whole team plays a very, very big role here.
Particularly in a patient with a PEG, in the endoscopy role is expanded from a nursing perspective, because you may have a connection with the patient before and during and after the procedure, and you want to have them educated throughout the whole time. So in the PEG scenario, you have the physician involved, the patient involved, the family involved, nursing involved, as well as nutrition and dietary, and then leading on to a home health care scenario. So it's a true collaborative effort, because as opposed to other endoscopy procedures where the patient has the procedure and they have no outer external sequela, here in this case you have a patient who has some device who needs to take care of it in the future. So it's
all that education is really nursing. You're going to be the one that's doing most of that education, if not all of that education. So super important is the job of the nurse. So, questions before we move on?
Yeah. You're gonna have to know step-by-step procedure on that for the exam,
No,
details?
not for the exam.
Okay. Just for
However, there are, not for the exam. For this case study, yes.
Oh,
Okay.
case study.
And the reason that you're not going to be physicians, you're not going to have to put one in, but for a nurse to manage something, if you don't know how it got in there, or what it's doing in there, or how it's placed in there, it's pretty hard to assess it. Like if you just know it exists, you know what I mean? So I think it's important for you to understand how it got there, and the bolster that's in there, if it's a hard bolster, if it has water in it, so when you're troubleshooting it, you can make some good decisions. Anybody in Rochester?
All right. Any questions? Nope.
Nope. All right. So feedings can be started when bowel sounds are present, generally 24 hours after placement. That is very important for you to know. Immediately after the insertion, the tube length from the insertion site to the distal end should be measured and recorded. Why? Because you know if it's migrating in or out, right? So it's part of your assessment. Where is it in the stomach, right? Where in the world is Carmen Sandiego? Is that the deal we play? Or what's the other game with the guy with all the stripes?
Oh, where's Waldo?
Where's Waldo? Sure. So, all right, tube feeding administration, patient positioning should be sitting or lying with head of bed at 30 to 45 degrees. Remember, you don't want to, sometimes having the head of the bed higher can also increase risk for pressure ulcers, which you guys will talk about here in a while. So you do just need to make good decisions. Which is your patient more at risk for, and what degree is going to be best for your type of patient. That head of the bed, regardless whether it's at 30 or 45 degrees, it needs to stay elevated for 30 to 60 minutes after you've delivered the feeding, okay? So nursing considerations, daily weights. Why would we care about daily weights? Anybody? What would daily weights tell us? Yeah.
They let us know if they're losing weight, because if they were, then they weren't getting the proper nutrition.
Proper nutrition and proper hydration, right? So they need to have both. We would be getting concerned if they would be losing weight. So it's the easiest, least expensive way to make that measurement. Now, when you saw on the front of this, the turgor, right, and you're being taught turgor, that turgor that you see where the skin tints up like that is one of the last things that happens in dehydration, not the first things, okay? So you need to be looking for cracked lips, you need to be looking for dryness of mucous membranes, that kind of stuff. If you go in and actually find a patient whose skin tints like that, yeah, you better hurry, okay? Because that's gone on for a while, okay? Assessing bowel sounds before feedings all the time, okay? Accurate I&Os. So for the first, for the beginning, after the PEG tube is placed, you want to make sure that kind of what's going in is coming out and that you have some of each, okay? You will not necessarily be doing I&Os the entire time this patient has a PEG tube, okay? It's just in those initial days when we're trying to make sure everything is working. Glucose checks. Now I will tell you, yep, Claire. Input and output. So everything that goes in, liquid, and everything that comes out, liquid. Good question. Glucose checks are important because, first of all, and we'll talk more about this when we do glucose management, but patients who are sick generally have higher glucoses anyway, okay? And so if we have a really sick patient, that can play a part. But also, sometimes these formulas cause the patient to have higher glucoses. So we can see elevated glucoses even in patients who don't have diabetes, okay? That we may need to manage for a short time. And if they do have diabetes, we may be seeing higher numbers. So we may have to initially increase insulin or those kinds of things. So your food and your tubing are good for 24 hours. So if you come on shift and you find your stuff hanging there and it has no date or no time on it, what are you going to do with it? You're going to throw it out and you're going to get a brand new one. Okay, if it happens very often, you're going to let your nurse manager know because somebody is wasting. Okay, somebody's wasting resources. And they're also being very, very dangerous. All right? Because some other people might not be as prudent as you, right? So it's very important to label these things with the time and the date that they're started. Complications, you heard a bit of that on the video. So vomiting, diarrhea, we're thinking about really anything that could happen in the GI tract. Vomiting, diarrhea, constipation, dehydration. Again, that formula is more calorically dense. You're not getting as much hydration out of it. And then we can also have some issues with protein. So gastrostomy or jejunostomy, two potential problems: skin irritation. Remember, you're going directly into the stomach, okay? And so into the stomach, what's the pH of stomach contents? Eek! Way down. It's very, 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 very acidic. So 6 and 7 is pretty neutral. So you're talking about 2.5, 3-ish, okay? So that's going to burn your skin, okay? So if it's leaking, it's actually going to burn that skin all the way around. So it's super important to be doing good skin assessments and good care, okay? Sometimes patients pull them out, okay? Sometimes patients and family can be taught to put them back in, depending on why they're in there and how long that stoma has been able to heal. But the job of the nurse will also be to teach the family about feeding administration, tube care, and complications. So some of our gerontological considerations. So they're a really vulnerable population. Remember, for all the reasons we've already talked about, they have more problems with fluid and electrolyte balance. And we'll talk about that when we do fluid and electrolyte balance. Just know that anything that needs to be in balance, it's kind of teetering on an older adult, right? It doesn't take much to knock things off balance. Glucose intolerance, decreased ability to handle those large volumes. So again, we need to start slow, monitor residuals, and there is an increased risk of aspiration. Ta-da! We're done with that part. So, yeah, that's what I say. Any questions, thoughts? So what's going to happen next is I'm going to see if Juliana will pass out. There's two case studies. We're going to focus today, so I want you to focus, hear me, focus on the enteral feeding, not the spirituality and pain one. You can do the spirituality and pain one on your own at home. But here in class, we're going to do the enteral feeding one, and then we'll go over the answers, okay? So there are two handouts that you're going to be using, and then the stuff from the video. So this nutritional laboratory tests. So here you're going to be talking mostly about albumin, because that's one of the questions, okay? What is albumin and why do we care? What happens if it's high? What happens if it's low? Okay, so these are laboratory tests. And the other handout we have is what happens when a patient gains or loses a certain amount of weight, so involuntary weight loss, okay? BMI, what's going on with that? Physical examination findings for nutritional indications. So what does a person look like who's having a deficiency, okay? And there's also a little bit more laboratory data here that you can look at. Okay? Here's your metabolic syndrome. I would know this information down here as well. So you can work in your groups of 3, in your groups of 6, however you want to do it. And we will come back together around 5 after 4, and we will go over the answers. So please be sure to fill these out. These are actually what your ICA is today for those 2 points. So with no further ado, we'll move into that.
Everybody got your measure? Yeah. You need one? Oh, you're done at 3:45? Yeah.
So I'm gonna leave this on mute and see if otherwise it gets really hot for them. So
Where? The mute on mute button? Yeah, right there.
otherwise, if you have that hand.
Okay. Now you can always hear me through it.
Hey, I don't know if you, like, are you familiar with the course content and everything for this class?
Okay, yeah. I have access to all of it. Yeah.
Okay. So for this one, I think I'm gonna get a question on it. So for subjective health assessment, I'm just kind of curious why hair, skin, and nails is on there, and if that would have been objective.
Oh, so you're wondering if...
Right, like why it falls under subjective health assessment. I know it's a very like fine line thing, but I don't know. I feel like that just would be objective.
Yeah,
It's an
if you assess
observable
it,
thing.
yeah.
Right. It's not like what a patient's feeling. And it's a small thing, but I think I'm gonna get questions on it.
Okay.
They like to know.
Are you the pal?
Yeah.
Right. Okay.
Yep.
Okay. So you want me to let her know, or you gonna?
I can email her, but I was wondering if you knew why it was on there.
I know sometimes, I don't know how it goes for this class, but for us, like anything the patient reports to us.
Okay, so if the patient
they said,
were to
oh, my
report
hair's
it,
been,
sure.
falling apart.
So they could tell you like.
Yeah, so then that would be subjective. We actually went through all of that.
Oh, because
everything.
they were telling you
but
what it used to be.
It's actually a good question.
Okay, right. Okay, yeah, I'll email her about it, but that's a good logic though.
Yeah,
They
you
were
can
telling you
CC
what
me
it
on
was
that
like
too. I want to
before.
know her.
Okay, sounds good. Yeah.
Okay, thank you. You go. I'm on there.
Lily. Yep.
Thank you.
So we can say yeah, maybe. I'm trying to compare. Potential heart failure. I would say at risk for. This is overhydration. Yeah. Got all this. I couldn't
Visual description voluntary intake while they're marking. And then that's so even lower with and then that's when you
Why don't you work for another 5 minutes and then we'll come together and go over the answers.
I read out of the fundamentals.
Okay, let's come together. Are you guys ready in Rochester? Yeah? All right. Well, Ruben, he's not been doing so hot since he got into the hospital at all. So some of the things that I would say when I do case studies that make them easier for me is I might take particularly if you're doing an exam, a test question, or just answering something you have to hand in from now on, is to take and kind of think about what's the pertinent information in the dialogue, right? So if I'm going, through here, it's obvious he's pretty sick. Doesn't really matter what he has. Well, maybe not. Okay. He's 70 inches tall and he weighs 153. His usual weight is 180. So this group over here, Isabel's group, would you guys kind of talk about what we cared about with his weight? That was a good conversation you guys had. Yeah.
So we talked about
nice and loud so they can hear you in Rochester.
So his BMI at 180 is technically slightly overweight, but that's not really very important. And his BMI at 153 is still healthy, but it's not a matter of whether or not his BMI is healthy. It's the fact that he went from 180 pounds to 153 pounds because it's a super significant weight loss.
Good. Yeah. So it's an unintended weight loss. Okay. And we worry about that. And that was on one of your handouts. So if you got a case study and you saw that there was a greater than 5 pound weight loss, unintentional, you're going to start thinking, is something the matter? Okay? Remember, you're never going to take one piece of data and go running along and take care of the whole world on it, right? But you've got this thought. You're like, wonder what's going on. He's losing some weight. Did he mean to or not? No, he didn't. He's been sick. He does have a history of PTSD. Is that important right now? It's not really important right now in terms of his care. You want to keep that in the back of your mind because you saw the nursing care that she's providing. The only thing I would say is keep it in the back of your mind. You may not want to have sudden things go on or noises or that kind of stuff. Is it really pertinent to this case study? No. So it's there and you want to think about it, but it's not the most clinically significant data you have. 48 hours, his voluntary intake is reported to be poor. Is that important? Yeah, it means he's not voluntarily doing anything that you want him to do, like eating and drinking and those kinds of things. He's unable to communicate effectively. Is that important? Yes. Okay. Because that means that if he was communicating effectively before and he's not, his functioning has declined seriously, right? And that could be just due to nutritional deficiencies or getting sicker and sicker. So that does matter. He's unable to communicate, and he's also experiencing marked difficulty swallowing. Well, that obviously is very important to this particular case study. So there'll be things that are important and things that aren't so important. So let's go through those labs. I heard lots of conversation about them. So the bun at 42 and the creatinine at 1.9. Let's see here. Madigan, your group there. Bun and creatinine monitor what function? The function of what organ? Kidneys, okay? So, now, bun can have kind of a wide span, okay? They always go together, bun and creatinine, okay? And if you see bun rise kind of high, but your creatinine is not as high, it didn't make as big a jump, you might consider what is going on. Anybody? Anybody in Rochester? What might you ascertain? What might you think is going on with this patient if their bun and creatinine are those numbers? What do you think? Using the case study information, so he's not voluntarily, getting intake, both liquid and food, okay? And those are his numbers. Did you guys look at the nutritional handout? I think this group did. What did you guys come up with? What do you think? What might be going on?
When we looked at for elevated bun and creatine, we said that it could mean an obstruction of the urinary tract ketoacidosis or ketoacidosis.
Okay, yep.
If there's like an increased bun but normal creatinine, it can signify like dehydration.
Woo-hoo! There we go. So dehydration. We're not looking at as an elevated number of creatinine. So bun will go up significantly with dehydration. Creatinine, it crawls up just a little bit. Now, if they both go up a significant amount, you are looking at some type of kidney injury, okay? Something bad is going on, okay? This is more an indication of dehydration, which would go with your story, right? So again, you're gathering data, both subjective, objective, what's going on, okay? So sodium, it's 151, normal is 135 to 145. What are your thoughts? Could that also just be due to dehydration? Yes, okay. Potassium, 5.1, and I hate the word normal. It really should be reference range. 3.5 to 5. So is that 0.1 important? Boy, I heard a lot of conversations. What are your thoughts? 0.1. So 5.1, is it super important? Not as important? Ella?
It could be like indicative of a potential.
Okay, could be potential. How about Rochester? What are your thoughts? I know you have some. I've spent a lot of time with you guys. Come on.
You can go ahead, volunteer.
Yeah.
Since the reference range is smaller, I think that even that small increase could be more indicative of something going on.
I couldn't quite hear you. Oh, go ahead.
Since the reference range is smaller in the potassium, even that small increase could be indicative that something else is going on in the patient.
Okay. Yeah. So it's really not terrible, but it is at the high end of normal. And what you're going to find out is potassium is very, very important in the cardiac organ, okay, all the cardiac function. And if your potassium is too low or too high, you can have dysrhythmias, life-threatening dysrhythmias, okay? This is also really important, even though it's 0.1 over. Now, if a doctor ordered a medication, so let's say they wanted to do dextrose 5% in water with 10 of potassium chloride. As the nurse, you're going to look at these lab values and go, I do not feel comfortable giving any more potassium to this patient. Okay? This patient is already high in normal. Okay? And so I'm going to call the physician and see, does he really want me to do that? Okay? And that did happen at the VA, and we called the physician, and he'd actually put in a wrong order for a patient. So, no, he did not want to, but it was the nurses that caught that, okay? So it's very important to know, and you're right, the reference value is much smaller, so those little tiny increments can be more of a problem. Same way with like if it was 3.2, would you give replacement? Yes, I would give replacement at 3.2. I would monitor it because it's not like super low, right? I'd like to kind of get it up a little bit, but you do have to be careful you don't mess around. Good. Okay, albumin. Why do we care about albumin?
It's really important protein.
It's related to protein, yes, which is also used to monitor what? Nutrition. So albumin is used to monitor nutrition. Now, is it super sensitive? In other words, if someone is just starting to experience problems, will you notice, a huge drop in your albumin? No. But again, it's kind of like the potassium. You're noticing some shifts, okay? This is an elderly gentleman. He's down to 3.1. I would be concerned, okay? I would not take this 3.1 if that was the only piece of information I had and run off and call the doctor and say, oh my God, we need a PEG tube, okay? But all of this information together tells me what? He's dehydrated, right? And that he's having some nutritional issues, okay? And so he's also physically, functionally going downhill. So subjective, objective data tells me he's really not doing all that great. Maybe we need to step in for a little bit, okay? So is he a candidate, what do you think, for a PEG tube replacement, or PEG replacement? Yeah. Are there any contraindications? Anybody? No. Anna, is that what you were going to say?
I just said maybe the fact that he has pneumonia could be an issue.
Okay. And we do want to keep an eye on medical issues. Absolutely. Good. So he'd be even more at risk for aspiration pneumonia, right, if he got that on top of. Okay, so we need to be careful. But really, those things that it mentioned in the video and that I mentioned here in the PowerPoint, no, there really aren't any contraindications, nothing that would say we absolutely don't want to do it. Okay. So we've already talked about the laboratory data. So the PEG tube placed, I'm not going to go into a great amount of detail. What I want you to know is that it's important for a nurse to know how things are done if you are going to be the one that assesses it, okay? If you don't know what it looked like going in and where they put it and why they put it there and all of that, it's incredibly hard to manage and to know what you need to do or to troubleshoot, okay? So you guys can, if you want to, you can go through the video again and again. Things that I would say is that PEG tube placement is a conscious sedation, okay? That's important to know because it's less costly, okay? And the patient doesn't have to go and have it surgically placed, okay? They can do it at the bedside even, okay? So it's easy to do and it's not super expensive. So Ruben is having some leakage around his PEG tube insertion site. What do you think could be the problem? Anybody volunteer? Yeah.
Or he could be not positioned correctly during feeding.
Okay, good. Okay. What else? Margaret?
The feedings are too fast.
Feedings are too fast? How about in Rochester? There's one important one I'm looking for.
We said that the balloon may need to be inflated a little more.
Okay, good, good. What else? There's two more things
we also
on the video.
said gaining weight too fast.
Okay, okay. Xavier.
Yeah.
The formula that's being used, okay. How about the residual? Would it be too high or too low? Too high, okay?
Yeah.
So that's one thing that we would think about is checking those residuals. Turning down the rate, so it could be going too fast. Another thing is making sure that those, the tubes and the ports are closed properly. I can tell you that if you're not careful, when you open up those ports and actually bend it over or kink it, sometimes that fluid just kind of comes right out, which is super fabulous because it usually happens right after you make the bed and change the gown and give a bed bath, because that's the way Murphy runs. So make sure that you...
We had one more comment here.
Yeah.
Yeah, I was just going to say, like, you would want to check the residual because they might be having decreased GI function.
Perfect.
So things might not be moving through correctly and be coming out other ways.
Absolutely. You're exactly right. Okay, so last question. First of all, before I finish this last question, for those of you who aren't answering but you need to be listening, fill out those ICA forms if you haven't already. Okay, make sure your name is on them. Make sure that the date is on them. I don't know, does it say what the ICA activity was? No. And what I want you to do is write down 2 things that you learned today, okay, that you feel are important for your future nursing practice. And then we're also going to be talking about Ruben, who's experiencing some nausea and vomiting. So what are the causes and how can we intervene? The second one, what? Just 2 things that you thought were important that you learned today that would impact your future nursing practice. Yep. But we got to finish class here first, so what do you think? What might be the cause of that nausea and vomiting? Yeah, Gina. Eating too fast? What else? Yep.
Maybe the type of substance that you're giving him.
Perfect. Type of substance, maybe that formula. Xavier?
Temperature of the formula.
Temperature of the formula, absolutely. How about in Rochester? Oh, you guys, you're so far away. Come on now. Maggie, what do you think? I got to get out my thing here, so let's see. Who do we have here that I can call on? Because you're not giving me nothing there. Let's see. Sarah, what are your thoughts? Why would Ruben be experiencing some nausea and vomiting?
He's not handling the formula well.
Sure, he may not be tolerating the formula. Perfect. How about anything else? Some more things. And then, how can we intervene? What kinds of things would we... Oh, go ahead. I see you got the mic up. Wait, the little green light has to be flashing. You might have shut it off.
Just press it once and then, yeah.
Is it working now? There we go.
Yep.
Okay. Another thing that might be occurring is that he's not being positioned correctly
Perfect.
during the feedings as well.
Yep, good. Okay, so I know you're all itching to go, so I'm going to give you some answers. You guys named most of them. The nutrition might be entering the stomach too fast, so it might be we need to switch from a bolus to a continuous, which runs a little bit slower. It could be that the patient is not tolerating the feeding, which you guys talked about. The nutrition is too cold, perfect. And the residual may be too high. I think you guys talked about that as well. And if this goes on here for a while, we probably need to notify the physician. So don't forget to hand in your ICAs. You don't have to hand in your case studies. I would keep those and study from those. Okay? Any questions from Rochester? See you in the funny papers. Gonna go try.